So we'll start our lecture today about the prostate cancer. Prostate cancer part 1. Prostate cancer is the most common internal malignancy in males. Men will be diagnosed with prostate cancers in their lifetime. Approximately 12% of the men will be diagnosed with prostate cancer in their lifetime. Prostate cancer is the second leading cause of cancer-related deaths in men. However, the approximate lifetime risk of dying from prostate cancer is only 3% when including the men of all races. In men of the African ancestry, the lifetime risk of dying from the prostate cancer is approximately 2 times higher. So in African is 2 times. Nonetheless, most prostate cancer do not cause death. The most common type of prostate cancer is adenocarcinoma. So the presentation age usually present at the age of 65, but it can occur at any age. Most prostate cancer or patients with prostate cancer are asymptomatic. Advanced cancer might be present with home pain, voiding symptoms, hematuria, urine retention, and hydronephrosis. So metastatic of the prostate cancer from the commonest metastatic location to the least one. So listed from the most common to least common. Pelvic lymph nodes, bone, lung, and liver. Okay, so the common is the pelvic lymph nodes, then bone, and then lung, and then liver. Incidence of the prostatic cancer. 28 to 61% of the patients undergo radical cystectomy are found and have incidental prostate adenocarcinoma. This for the patient who undergo radical cystectomy, they have 28 to 61% have adenocarcinoma of the prostate. Up to 10% of the patients undergo transmural resection of the prostate or TURB are found to have incidental prostate cancer. This is up to 10%. During autopsy, older subjects have higher chance of having incidental prostate cancer. So the most of the incidental prostate cancers that are discovered during autopsy are microscopic and low grade. This is the chance of having prostate cancer, and this data is actually for men of 71 to 91% and 91 years. If we consider the age group of 20 to 29, have 8% risk of the decrease the subject. This is the incidental prostate cancer. Decrease the subject diagnosed at autopsy, and also PSA and digital rectal examination of the patient is unknown. So autopsy, this 20 to 29, 8%, 0 to 8%, 30 to 39, that's 60 to 6 to 31%. This is age group of younger, and 40 to 49, this is 13 to 43%, and 50 to 59, that's 20 to 55%, and 60 to 65, that's 32 to 70%, and also 70 to 79, this 33 to 83%, and here we have more than 80, that's 48 to 87%. So, and as you see here, the liver, the live subject diagnosed with prostate with PSA less than or equal for all age group have no any significant or percent in increasing, but the age group of 60 to 65 have only 14%. Very important. So 14% of this of those age groups have PSA less than 4 or equal 4, and normal digital rectal examination, they have prostate biopsy show prostatic cancer, chance of incidental prostatic cancer. And also more than 80 or equal 80 years old, that the incidence is 17%. Okay, so but the total is that's in the autopsy 48 to 87%. So the risk of prostatic cancer, family history of prostate cancer, African ancestry, and also age group of 40 to 50, and genetic mutation or syndrome that increase the risk of prostate cancer. Example for this BRCA mutation, KEK mutation, KEK2 mutation, and Lynch syndrome. So BRCA2 and KEC2 mutation. Family history of prostate cancer. The family history of prostate cancer can increase the chance of developing prostate cancer and increase the chance of dying from the prostate cancer. So each of the following family characteristics increase the risk of developing prostate cancer. The family member with cancer is a closer in relation first degree relative, that for example brother son or brother father son with prostate cancer import higher risk of cancer than second degree relative, that the grandfather, uncle, nephew, or grandparent. All right. So, and also compare with the third degree relatives, that cousins or great grandfather. So the higher risk for family member with a first degree relative like brother, father, uncle. The family member was diagnosed at younger age, particularly age of less than 65 years. This is the family member. A great number of family members have prostate cancer, or having a first degree relative with prostate cancer increase the risk of dying from prostate cancer. Each of the following characteristics contribute to increase the risk of dying from the prostate cancer. That first degree relative was diagnosed at age of less than 60 years, and also greater number of the first degree relative have prostate cancer. Each of the following characteristics contribute to increase the risk of dying from the prostate cancer, that the first degree relative was diagnosed at the age of less than 60 years, and also a great number of the first degree relative have prostate cancer. This is the number of the first degree relative with prostate cancer, and this relatively increases in the risk of dying from prostate cancer. So this is if you have one first degree relative, that's increased 2 to 3 times greater. So if we have two relative, that's 3 to 6 times greater. If we have three, that's 8 to 10 times greater. So this is increase in number compared to the main first degree relative did not have prostate cancer. So African ancestry, that's men of the African ancestry have been referred to in some study as black man, or for a study conducted in the United States as African American men. Men of the African ancestry are more likely to develop prostate cancer and are more likely to diagnose at the earlier age. Men of African ancestry are more likely to have an advanced stage of prostate cancer at the diagnosis, to have more aggressive cancer, and to die from their cancer. Age at diagnosis, prostate cancer is rare in the men less than 40 years of age, and we saw the percentage previously. And the risk of the prostate cancer increase after the age of 40 to 50. More than 90% of prostate cancer are diagnosed in the men of 50 years of age. Median age of diagnosis is in the United States is 66 years. And genetic mutation and prostate cancer. Mutation can be classified based on whether they are inherited in the prostate gametes at the time of the conception. That's known as germline mutation. So this is inherited that from the parents' gametes at the time of the conception, known as germline mutation, arise from non-gamete cells after the conception's somatic mutation. So we have the germline mutation and we have somatic mutation. Germline mutation, this genetic mutation, are inherited from the parents at the time of the conception and are copied into the all cell in the body. Also, it may not be present in all gametes. The mutation can be passed from the generation to generation. Tissue required from germline testing. Theoretically, tests can be performed using any nucleated diploids, that's non-gametes cell because they contain a full complement of inherited DNA. However, testing is typically done using lymphocytes from a blood sample and or buccal mucosa cell from a saliva sample or from buccal swab. Population in which Germline testing is utilized patient with or without cancer. Reasons to test for Germline mutation in the person without cancer. Testing can be determined the risk of subsequent developing cancer and the risk they might pass a mutation to their children. In person with cancer, testing might guide treatment. Some theory or therapies may be more effective when certain mutation is present, may help refine the prognosis of existing cancer and may help establish the patient personal risk for the other cancer. Some genetic syndromes are associated with multiple cancer, may be determine the risk of passing the mutation to their children, and may ascertain if the family member may be at the risk from having the same mutation. Somatic mutations, these genetic mutations are acquired after conception. Therefore, they are not inherited and cannot be passed to the next generation. Somatic mutation arise only in some cells in the body, such as within the cancer cell. In a cancer with somatic mutation, the genetic involved and percent of the cell affected may change over the time because of genetic instability within the cancer and selective pressure from the cancer treatment. Most mutations in the cancer are somatic rather than germlines. So tissue required for somatic testing, a sample of malignant tissue is required. Population in which somatic testing utilizes patients with cancer. Therefore, here we have reasons. Reasons to testing for somatic mutation to guide treatment. Some therapy may be more effective whether a certain mutation is present or to help better define the prognosis. If cancer has a certain mutation, the mutation may have arising from either genetic aberrations in the cancer, somatic mutation, or from the patient inherited disease known as germline mutation. If the patient has certain germline mutation, the same mutation will be present in the patient's cancer. Unless genetic instability in the cancer has removed the mutation. This is a comparison between two mutations that's associated with the prostate cancer. We have germline mutations, that's a germ cell, and we have somatic mutation. So origin of mutation, germline mutation that inherited from the parents and spontaneous mutation within the cancer, somatic, can be treated to offspring. Yes, this is inherited. Yes, we can treat the offspring, and this cannot be treated to offspring. Cell in which mutation is present, all nucleated diploid cell in the body, here some or all cancer cell. Here only cancer cell, but here all nucleated diploid cell. Population in which testing is utilized with or without cancer must be testing for the germline cell or all nucleated cell in the body. With cancer, here must be testing. So those group must be testing for somatic mutation with cancer. Tissue source typically used for testing, we'll use lymphocyte and we'll use buccal cell. So buccal cell and lymphocyte from buccal swab, for example. So cancer cell, only malignant cancer cell must be testing in somatic mutation, but here in germline we'll test lymphocyte and buccal. Predicted risk of developing cancer in the future. Yes, germline can detect, and also here is not. The somatic mutation cannot predict the cancer in the future, but the germline can predict. May help guide treatment of existing cancer. Yes, here also yes, can in somatic also yes, in germline yes. May help divine prognosis of an existing cancer. Germline yes, and also somatic mutation yes. Genetic mutation that increase the risk of the prostate cancer. Certain genetic mutation can increase the risk of developing prostate cancer. The genes in which this mutation occur can be categorized according to their function. In some cases, the gene may be involved in more than one function. When in their normal unmutated form, many of these genes repair error in the DNA, such as gene involving in homologous recombinations repair, that's HRR. This is very important, or mismatch repair. When one of these DNA repair gene undergo mutation, it loses its normal function. Therefore, the DNA error are perpetuated rather than corrected. So this unrepaired error in the DNA can cause cancer. This is example of the gene that's increase the risk of the prostate cancer categorized by function. So this is the DNA homolog recombination repair, HRR. All this is considered as a gene that increase the risk of the prostate cancer categorized by function. And here this is a DNA mismatch repair gene that also increase the risk of the, and this is the regulation of other gene that increase the risk of the prostate cancer. We'll start by regulation of the other genes at HOXB13. DNA mismatch, it's MLH1, MSH6 and 2, and BMS2. All this is a DNA mismatch, remember it. And here we have DNA homolog recombination repair. That's the ATM and ATR, BRCA1, BRCA2, and we have BRIB1 and CHEK2, and we have FAM175A and Gene1, and we have MRE11A, and we have MSH2, as well as in the DNA mismatch repair. Here we have DNA HEHR, that's MSH2 and MSH6, and also NBN is also considered as DNA HEHR, and we have BLAB2 and BMS2 as well as in the DNA mismatch repair, and we have RAD51C and RAD51D. All this is included as a DNA HEHR. More aggressive prostate cancer are associated with higher likelihood of having a germline mutation. Also, men with the intraductal, ductal, or cribriform prostate cancer are more likely to have germline or somatic mutation. The cancer state: if the cancer localized, low, intermediate risk, that's the chance of germline mutation related to prostate cancer is 2%. If localized and high risk, that's the chance of germline mutation is related to prostate cancer is 6%. And if metastatic, that increase the percent by two times of the localized high risk of germline become 12 to 16% chance of germline mutation related to the cancer in metastatic is 12 to 16%. BRCA1 and BRCA2 mutations, or BRCA, BRCA2 mutation, both BRCA1 and BRCA2 mutation increase the risk of multiple cancer, including prostate cancer, male breast cancer, female breast cancer, ovarian cancer, pancreatic cancer. BRCA mutation are inherited in the autosomal dominant fashion. BRCA1 mutation, there is conflicting evidence as to whether a germline BRCA1 mutation increase the risk of the developing prostate cancer. Here we have conflict about one. Also, evidence insufficient to determine if BRCA1 mutation influence the aggressiveness or lethality of prostate cancer. But the BRCA2 mutation compared to men with normal BRCA2 gene, men with germline BRCA2 mutation are 2 to 6 times are more likely to develop prostate cancer. So we have BRCA2 mutation is more significant. They are also more likely to diagnose with prostate cancer at the early age groups. So at the early age to have a more advanced stage and diagnose, and also to have a more aggressive cancer, and also to die from their cancer early. This is a patient with BRCA2. Also more likely to diagnose with prostate cancer at the early age, and also have more advanced cancer, and also have more aggressive cancer, also die from the cancer. All this come with BRCA2 mutation. And here it is 2 to 6 times more likely to develop prostate cancer. BRCA2 mutation are most common germline mutation in men with metastatic prostate cancer. Compared to general population, That's the jaws of the Eastern European ancestry. That's Ashkenaz Jews are 10 times more likely to have BRCA2, BRCA mutation, BRCA1 or BRCA2 mutation occurring to 2% of Ashkenazi Jews and in 0.2% of the general population. So those groups have increased BRCA1 and BRCA2 mutation. That's 2%. But in the all general population is 2%. Men with BRCA mutation and metastatic castrations-resistant prostate cancer may candidate for treatment with BARB inhibitors. That's this patient with BRCA mutation and metastatic castration resistance. It is better to manage with BARB inhibitors. Men with BRCA mutation and metastatic castration resistance can be managed by BARB inhibitors. DNA mismatch repair gene, that's MLH1 and also MSH1 and MSH6 and BSM2. A mutation in any of these genes can increase the risk of developing prostate cancer. A mutation in these genes can cause a loss of their normal function, resulting in deficient mismatch repair, that the DMMR of the DNA. Deficient mismatching repair. This can occur in the patient with mutation of the MSH2 and 6 and BMS2 and MLH1 and have a risk of developing prostate cancer. The presence of the DMMR lead to microsatellite instability, that's MSI, which is predisposition to developing the further mutation. Testing for mutation in these genes can be performed using assay for either DMMR or MSI mutation are present when DMMR or MSI are present. The degree of MSI can be classified as MSI high, that MSIH, that high, or MSI low, that MSHL, or MSI intermediate, that's MSI I, or MSI absent, that's MSI absent is called microsatellite stable, that MSS. A high risk of prostate cancer is mainly associated with MSIH. Lynch syndrome, hereditary non-bulbous colorectal cancer, that's abbreviation of the Lynch, and autosomal dominant syndrome. Lynch syndrome increased risk of developing multiple malignancies, include prostate, upper urinary tract, colon, rectum, small bowel, stomach, biliary tract, pancreas, endometrium, and ovary and brain. This is all cancer associated with Lynch syndrome, but remember the prostate can occur. It arises from germline mutation in any of several genes, including DNA mismatch repair genes such as MLH1, MSH2, MSH6, and BMS2. So this is with Lynch syndrome. Lynch syndrome increases risk of the developing prostate cancer by 2 to 6 folds. However, this as well as BRCA mutation. However, it does not appear to alert the age of the onset or aggressiveness of the cancer. So men with DMMR or MSI are at risk of Lynch syndrome. Remember this. When the MSI or DMMR is present, the patient is candidate for treatment with pembrolizumab. So if we find this MSI or DMMR, we treat the patient with pembrolizumab. And HEC mutation, KEK mutation. The KEK mutation, particularly 115/70T, this mutation increases the risk of developing cancer of the prostate, kidney, specifically clear cell carcinoma with KEK mutation 2. So clear cell with KEK mutation 2. Also breast cancer, male, female, colon, and thyroid. But remember, KEK mutation 2 is associated with prostate cancer, kidney. Okay, this is as urological. but other breasts for male and female colon and thyroid. If the patient has known or suspected genetic susceptibility to prostate cancer, he should be referred for genetic counseling. So what the testing for genetic abnormalities in the men with prostate cancer? Germline genetic testing should include testing for BRCA1, BRCA2, ATM, BLAB2, CHEK2, and also MLH1, MSH2, MSH6, BMS2. This must be done. Germline testing is recommended in men with prostate cancer and any of the following characteristics present. If the patient have high risk localized prostate cancer, if the patient has regional or distant metastatic from the prostate cancer stage N1 or M1, ductal, intraductal, or cribriform pattern prostate. So if ductal, intraductal, or cribriform pattern prostate, this must be testing for Germline test. If the patient have regional or distant metastasis from prostate, that's N1, M1, ductal, intraductal, cribriform pattern prostate cancer. Family history that meets any of the following criteria must be tested for Germline. Brother, father, multiple family members diagnosed at the age less than 60 years with grade 2 prostate cancer. Brother, father, or multiple family members who died from prostate cancer. The Ashanxi Jewish group or ancestry. Those must be testing. Family history of Germline mutation thus increase the risk of prostate cancer. Example, BRCA2, Lynch syndrome, and CHEK2. Family history of 3 or more of the following cancer on the same side of the family, especially when diagnosed at the age of less than or equal 50. Prostate with grade group more than 2, urothelial cancer, kidney cancer, gastric, bile duct, pancreas, and small bowel, colorectal, breast, ovarian, endometrial, and melanoma. So if the patient have cancer of this, those must be considered as very important to do Germline test. Prostatic intraepithelial neoplasia, that's the BIN. BIN is dysplasia of the prostate epithelial cell. These dysplastic cells are inside the gland that have basal cell layer. BIN is categorized as low grades or high grades. BIN often coexists with prostate cancer. The presence of BIN does not seem to raise the serum PSA. Focal high-grade BIN is typically defined as 1 or 2 sites of involvement. Multifocal high-grade BIN is typically defined as 3 sites of involvement. So this is the focal high-grade defined as BIN typically defined as 1 or 2 sites of involvement. 1 or 2 is considered as focal high. Multifocal high, that is as actually 3 sites of involvement. Low-grade BIN and focal high-grade BIN do not increase the risk of developing cancer. Remember it. But the multifocal high-grade, that's 3 sites involved, 3 sites BIN, increase the risk of developing prostate cancer. After 10 to 12 core biopsy, 10 to 12 core biopsy, core systemic prostate biopsy, approximately 30% of the men with multifocal high-grade BIN will develop prostate cancer. A great number of foci with high-grade BIN correlate with high risk of developing cancer. It is important to distinguish the high-grade BIN from ductal or intraductal prostate cancer because they can have a similar appearance of on histology. This is the importance of the high-grade BIN. When the pathology report reveal extensive high-grade BIN but not prostate cancer, consider having the biopsy reviewed by pathologist with expertise in the prostate cancer to rule out the ductal or intraductal carcinoma. This is the end of the first session of the prostate cancer. We will meet again in another one. Bye-bye.